So today we're going to be talking about tuberculosis and the eye. And TB is just like syphilis, it's a great mimicker. So we should be considering tuberculosis in any unexplained neuro-ophthalmic finding, especially, however, if the patient has risk factors. And the risk factors for tuberculosis worldwide are if you're from an endemic area. So many countries in the world have syphilis and tuberculosis that are at endemic rates, and so you need to know kind of the map of the world of where the countries that still have tuberculosis are. In addition, in the United States, we're going to be thinking about healthcare workers like ourselves, and that's why we're tested yearly for tuberculosis, because we're exposed. People who are in crowded situations, homeless people, prisoners, and in our state, especially Texas, new immigrant populations. So the questions for these people are, did you come from an endemic area, and how soon did you come? Like 3 years ago, 5 years ago. So if you're within 5 years from an endemic area, we really should be still considering tuberculosis in the differential diagnosis. And TB can affect the entire eye, all the way from the front of the eye to the occipital lobe, and so we should be thinking in any unexplained inflammatory process. That means episcleritis, scleritis, conjunctivitis, uveitis, intermediate uveitis, pars planitis, posterior segment involvement, chorioretinitis, retinitis, vitreitis, optic neuritis, scleritis. So if you've got itis anywhere in your eye, it could still be TB. And normally it looks like granulomatous disease. So we have it in the differential diagnosis of all the patients who have, where we're thinking about sarcoid, a non-caseating granuloma, tuberculosis still in the differential, a caseating type of granuloma. And really the only way to differentiate these two is with pathology. They look the same. So just like sarcoid can do anything and syphilis can do anything, tuberculosis can do anything. But really you should be thinking about it when we see that granulomatous type of uveitis in the anterior or the posterior segment. Inside the head, we're going to be thinking about meningitis, myelitis, meningoencephalitis, and it can present with unexplained cranial neuropathies or optic neuritis, optic atrophy, optic disc edema, and optic disc edema with a macular star figure, infectious neuroretinitis. We should be thinking about tuberculosis in those settings. So TB should be on your differential pretty much every time, but especially in high-risk populations, immigrant populations, travel to or they're from an endemic area. And we've moved away from the skin test, which is the purified protein derivative, the PPD. And in our center, we're now using the interferon gamma release assay. The interferon gamma release assay has various names, different companies, quantiferon, TB spot test. But the interferon gamma release assay is less susceptible to the problems that we had with the PPD, where we had to have it reread. You have to come back 2 days later. It's a blood test. It's way faster. And people who have received the BCG vaccine are less likely to have a false reaction if you use the interferon gamma release assay. And we pair that with a chest x-ray. So if the patient is not symptomatic pulmonary-wise, they've had an interferon gamma release assay that's negative and a chest x-ray that's normal, I think that's pretty good for excluding tuberculosis in our neuro-ophthalmic patients. So bottom line, you should be thinking about TB in any of these risk factor patients, endemic areas, immigrants, any unexplained anterior posterior segment inflammation, and in the brain, any type of unexplained optic atrophy, unexplained oculomotor cranial neuropathy in high-risk patients. And we're moving away from the PPD towards just using the interferon gamma release assay and the chest x-ray.